Welcome to the EATG Scope Community Meeting. For the coming hour and a half, we will learn and discuss the latest developments in PrEP implementation issues with community representatives, researchers, and activists. Before I continue this introduction, you will have noticed that our slides are translated in Russian. And this is because this webinar is entirely bilingual, and Olga and Vladimir are providing live interpretation. To access their interpretation, please select your preferred language in the interpretation option. And I would also like to remind everyone to speak slowly and clearly to facilitate the translation process. Please keep your microphones muted unless you are invited to speak by the moderator. You can also ask all your questions in the Q&A, as well as message or email Kiala if you experience a technical problem. This meeting is also being recorded. My name is Hirwa Wolf. I am a trans man, originally from Rwanda, and I am based in Belgium. As mentioned earlier, this webinar is held by the EATG's SCOPE project. The SCOPE project aims to strengthen community engagement to reduce gaps in access and use HIV combination prevention interventions. This platform that we are sharing today is a part of SCOPE's goal, encourage mutual learning and support, and equip communities with scientific and technological knowledge. This is why we will listen to a fantastic panel of speakers today, who will be, by the way, very welcome to correct me if I mispronounce their names, and please include your pronouns when presenting yourselves. I'm very happy to welcome Cindra Feuer. Sorry if I pronounce your name badly.
That was perfect. Perfect. Thank you.
Who will be presenting on PrEP and access options. Sarah Demart and Grâce Ntunzwenimana, who will share with us their research on PrEP use among migrant women in Belgium, and Amanita Calderon and Erika Castellanos, who will further explain to us community access challenges. Last but least, it is my pleasure to introduce today's moderator, who is Annie, I think, today.
Aisuluu joined, so it will be Aisuluu.
Okay. Today, moderator Aisuluu Bolotbaeva, sorry again, member of the ATG's Combination Prevention Community. Before we start, I encourage you all to ask your questions in the Q&A, as well as message or email Kiala if you experience a technical problem. Now, I would like to give the floor to Cindra Feuer, who is joining us from New York. Cindra is a senior program manager at AVAC and a steering committee member of International Rectal Micro-Based Advocates and the WITS RHI Key Populations Program. Cindra, I'm happy to hand over to you.
Thank you so much, and hello, everyone. I am a fast-talking New Yorker, so I will try to slow down. Please interrupt me if I'm going too fast. Going to share my slides. Let me know if you can see them. Oops. Can everyone see them? Okay. I assume you can see them. So thanks for the invite to speak. Just so you know a little bit about me and AVAC. AVAC is an AIDS advocacy, global AIDS advocacy organization, and we really advocate for HIV prevention around the world. I am a queer cis woman, she, her. I've been an AIDS activist and human rights activist and economic justice activist for many, many years. And it's always a pleasure to be speaking with EATG participants. So today I'm going to talk about PrEP access. We are in a precarious place in general in the epidemic. PrEP access is increasing, but we are far from out of danger. And when I say PrEP, I'm really talking about oral PrEP, like oral pills, daily oral pills, the new vaginal rings, and cabotegravir long-acting injectables. And I'm going to speak a little bit about access to all three of those categories. So I'll give you a global overview today in the next 15, 20 minutes of the scale up of PrEP, and specifically oral PrEP, long-acting PrEP, and how to accelerate global access. Give me 1 minute, please. Sorry. So I was saying, we are not really globally, the number of new infections, it has steadily been going down, but not nearly as quickly and widely as we have been expecting it to. We have a target of about 370,000 new infections in 2025. And in the last measurable year of 2021, we were only down to 1.5 million. So we had 1.5 million new infections in 2021, and we need to get down to 370,000 in 2025. Will we make these targets? I think a lot of it really depends on PrEP rollout. Okay, here we go. So we've got a whole bunch of different HIV prevention interventions. Today I'm talking about PrEP in the context of all of these other interventions. And PrEP is a highly, highly effective way of preventing HIV, and this is why we put a lot of resources into it. And today I'm going to talk about the antiretroviral based PrEP. So PrEP that's made out of these medications. So oral PrEP. What we have for oral PrEP, as many of you are probably familiar with, is we have the daily FTC TDF, also known as Truvada, and this is being rolled out in many countries in Europe. And then we've got another version of that, which is TAF, which is not necessarily being rolled out wide scale, and it's not for people who have vaginal receptive sex, and it's very expensive, and we're not going to talk much about that. And then there's 211, which is on-demand PrEP, which is that you take it 2 times before sex and then after sex. And these are the oral interventions. Oops. Okay. So I just want to put this study out there about oral PrEP. We've had oral PrEP in circulation on the globe. Study results about 13 years ago. The US FDA approved, was the first country to approve oral PrEP 11 years ago. And the WHO provided guidance in 2015. So oral PrEP has been with us for over a decade. And this is a map of the world and how well we've done in scaling up oral PrEP. This is only oral PrEP. So if you see, we had a target in 2022 of reaching 3 million people. We didn't. I'm sorry, by 2020, we were supposed to meet 3 million people on PrEP. We didn't meet that target. We have finally, in 2023, come to 3.8 million people. But there's a new target. The new target now is that by 2025, 10 million people who are highly likely to seroconvert will be initiating PrEP. And if you focus in on Europe in the middle, it has a lot of room for improvement. But I just want to say that there's good news that if you look from the left to the right, the rate of initiation of PrEP has really been accelerating. So in 2022, between 21 to the end of 22, the number of people initiating PrEP almost doubled. So if we can keep that rate going, that pace, we're in good shape. However, what I just showed you, that rate of initiation, it's only people starting PrEP. But there's been studies that show that most people who start PrEP after 1 month, only about 20% remain on PrEP. After 3 months, only less than 5 people remain on PrEP. And up to 6 months, it's way less than 5% are still on PrEP. So we have a long way to go. We really need to figure out what that is and maybe some alternatives. What are the reasons for that? And maybe some alternatives. And again, here, this just on the left just highlights where we are as far as PrEP uptake, PrEP use, and then where we really need to go. So we're here now, and like I said, we're at about 3.8 million PrEP users now in 2023. So we're not reaching our target. Our target now in 2023 looks like it's about 5.5 million, and we're only at 3.8 million. And then we still have all this space to go to get to 10 million. We're not reaching it. We're still in danger. And then just to give you an idea of what's going on in Europe, in Eastern Europe, the target for 2025 is to get to here, which is about, looks like it's like maybe 350,000. And if you can see the blue bar, which you can't see the blue bar because there's not many people in Eastern and Central Asia who've initiated PrEP. And then if you go over here, we've got Western Europe and Central Europe. They're doing a lot better with about maybe 400,000 people on PrEP, including US. But if you look up here, this is the target. So the target is almost 3 million. We're not anywhere near there. And those are our 2025 targets. So we're not doing great. We need a lot of help in expanding oral PrEP access. So what are, I just wanted to show you what's going on specifically in Europe. There's 30 countries that have PrEP guidelines, and these are really important. These actually help national programs roll it out, according to these guidelines. There's 15 countries with no guidelines, and the reasons being that they say their concerns for not rolling them out or rolling them out on very small scale is because they're afraid of increasing other sexually transmitted infections due to lower condom use. The drug costs are too high, and they're concerned about people not adhering. So these are some of the reasons why it's not being rolled out. 17 countries have reported no formal PrEP implementation at all. And PrEP is actually reimbursed in 23 out of the 55 countries, but it's not available in everywhere in each country that there's programs. And eligibility for PrEP is very limited is very limited for migrants and people who inject drugs. These are the populations that really have problem accessing the programs that already exist. And then there's 15 countries with generic PrEP in their healthcare settings. Generics are available in oral PrEP and are very important to access in Europe. And the ECDC has put out operational guidelines that each country can adopt. So it's important, after 11 years of PrEP rollout, oral PrEP rollout, it's important to see what we have learned and apply those lessons to expand the rollout of oral PrEP and the new interventions like the ring and the injectable. So what have we learned? We learned that it's really important to invest in and expand demand generation. And that can be that's just getting people to know about it. And globally, what's been done, or in Africa, what's been done is socializing PrEP for the general population, telling everyone that if they're at risk for HIV, then they should know about PrEP. And then there's more outreach specifically with populations who we know are at risk, like sex workers and gay men, et cetera. But I wonder, is this the best approach for Europe? Is it where it's not, HIV is in these subpopulations of key populations. It's not in the general population. Maybe in Eastern Europe it is more, but is that a good strategy for Europe to target the general population or to get more specifically to the specific populations? And maybe we can talk about that in discussion. And then we want to, what we've seen that's really successful approaches have been the differentiated delivery models. This is using really trying to bring the delivery into the communities and not in the formal medical clinics or formal settings where ARVs and treatment are provided. So that can be anything from mHealth, which is like mobile phone health, multi-month dispensing where PrEP is given for 3 months or 6 months at a time. So people don't need to come in all the time. And they can also do HIV self-testing. So they don't have to, again, go to a clinic all the time. Integration of PrEP with other sexual and reproductive health services is a really efficient model of finding people with HIV and servicing them with PrEP. And always a community-led service with non-discriminating providers is always the best. And we all know, we know that we need to increase resources, meaning funding for HIV prevention on the national scale. A lot of money goes to treatment, and that's great. We never want to take money away from treatment, but we want to increase the money for prevention as well. And building these infrastructures will pave the way for new prevention down the road. So I'm going to talk about long-acting PrEP. So to the right of the arrow, we've got the dapivirine vaginal ring, and I'll go into this a little bit in the next slide. And then we also have the cabotegravir long-acting injectable. The dapivirine vaginal ring is a monthly. Let me go. Here we go. So this is what it looks like. It's for cis women with vaginas. It was actually the EMA, the European Medicine Agency, actually gave a positive green light on this in 2020. And the WHO provided guidelines in 2021. So it's fairly new. However, it's not available in Europe. So let me just say what it is really briefly. It's a silicone ring and it's placed up into the vagina. The woman initiates it herself. She inserts it herself on a monthly basis. She leaves it there for a month. It's discreet, meaning no one knows about it. Not even the sexual partner can detect it. It doesn't interfere with sex at all. It's very, very safe, and it's non-systemic, meaning that the drug does not seep into the bloodstream and it does not circulate throughout the body. So it's just localized in the vagina. The drug, it's an ARV, an antiretroviral drug, and it releases slowly over the month out of the ring. It's the first ever long-acting HIV prevention product, but there's no regulatory approval in Europe. So my question to the European audience is there a demand for this? Is this something that women would want? And if so, what do Europeans need to do to get it? It's already been approved in several African countries, and there are implementation projects underway. So I'm going to move away from that because this is not, the dapivirine ring is not something that's being accessed at all in Europe. And I'm going to move, and it's not even, there's no regulatory approval in Europe. So that's for a whole nother webinar. So, but we are going to move to talk about long-acting injectables. For most of you, I think you know that, just broadly speaking, it's a shot every 2 months with the ARV drug cabotegravir, and it's a shot in the butt, in the buttocks, in the ass. Every 2 months, you have to go into the clinic and get the shot. So that's 6 times a year. You get a shot 6 times a year, and you're done. You have HIV. You're prevented from HIV. So where are we with this? The WHO released guidelines about a year ago. So this is a very, very new intervention. It's only been approved for use in the US, Australia, Zimbabwe, South Africa, Malawi, and Botswana. The company, the maker of it, ViiV, has actually filed for regulatory license in Europe, the European Medicines Agency, and in the Ukraine. There are still, so we have efficacy. We know that it works. It works even better than oral PrEP. They're both work almost, they will both protect you almost 100% of the time. But there are still questions about cabotegravir. I don't know if I should go into those questions. There are questions about them, but the good, like, okay, for example, will taking it cause resistance to that particular drug class, which is integrase inhibitor, and that drug class happens to also include dolutegravir. Dolutegravir is the primary treatment drug. So you don't, for anyone who is HIV positive. So you do want to be really careful about anything that might cause resistance to the #1 treatment drug. There's a lot of questions. There's a lot of questions about what HIV tests while on cabotegravir are the best and strongest to detect a breakthrough infection, and is there resistance, and lots of questions about how to implement this new radical and somewhat more medicalized HIV intervention. And there's a lot of sub-studies trying to answer all these questions, but importantly, there are a lot of implementation studies, also implementation projects across the globe that are trying to answer a lot of these questions. And let me just go back and say implementation, we're going to spend some time on these implementation projects. These are usually the first steps in the rollout in introducing the product to a country. It's basically, it's rolling it out at the same time you're answering some of these questions that are unanswered. So in low and middle income countries, both PEPFAR and Global Fund have gotten really behind this. They're putting a lot of funding into it. The problem right now is that ViiV, the manufacturer of cabotegravir, does not have a lot of stock, a lot of the drug. It's a lot more complex to make than an oral tablet. So they actually have to build more factories, more manufacturing mills to make the drug. So it's going to take several years to get enough drug for full scale up. Fortunately, ViiV has sub-licensed to the medicines patent pool, generic licensing. So there's now 3 generic manufacturers who have licenses to also go ahead and manufacture generic versions of cabotegravir injectables, but also they need to build their factories first. So we're not going to have, a huge stock for several years. And there's also, so on the advocacy level, there's the Coalition to Accelerate Long-Acting PrEP, and I'm going to talk a little bit more about that in a second. Just really briefly, more about the implementation studies. They're looking at, like I said, they're across the globe. They're looking in different settings, and they're implementing cabotegravir in different countries, different populations to answer some of these questions about resistance and and the best testing algorithms in what populations and how to best deliver it. And they're usually rolling it out with oral PrEP and the ring in these implementation projects.
Cindra,
yes.
Just to say, we're getting to the end of your time.
Okay. So there's all different service models that they're looking at, all different populations and all different places. And I'll just show you here. This is where all the implementation projects are planned. And if you look in Europe, there's one in France, one in Belgium, and one planned for Ukraine. And so these will be the first places that start to roll out cabotegravir. And these are the populations that out of all the 29 implementation projects across the globe, these are the populations that are being included. And for Europe, maybe it's something to consider that there's no people who use drugs are included in any of these studies, these implementation studies for cabotegravir. Only 3 studies have gender nonconforming people. 5 of them have trans men. And what else did I think was interesting from here? I think it's a big deal that there's no drug users in any of these studies. So how do we accelerate PrEP access to cabotegravir? We need to market it, normalize it, socialize it, and we're hoping that packaging it as choice, as part of a choice, whether it's oral PrEP, the ring, cabotegravir, condoms, treatment as prevention, that it's a choice. And the more choices people have, the more prevention they will access. Again, we need to identify the best service delivery. Where's the best place for people to access PrEP? Like I said, we need to understand the testing needs, the testing algorithms. We need all of you and civil society advocates and activists and implementers to really get engaged at this very beginning stage in the implementation projects that are happening in their countries. And if not, then get engaged with the policymakers and all the people to get them to implement in your country. Funding is a really big deal. We need generic cabotegravir because, of course, they're price gouging. It's too high. So there's a lot of work to be done there. Providers need to be trained in this new medicalized intervention. And we need to set targets for each country and each population. And we need to do a lot better than we did with oral PrEP and with COVID vaccine distribution. And this is my last slide. As I had mentioned before, there's the Coalition to Accelerate Access to Long-Acting PrEP. And this is my organization is the Secretariat, and it's convened with UNITAID and WHO and UNAIDS Global Fund PEPFAR. And basically the 4 things that this coalition is working on is intellectual property to get generics made, and voluntary licenses within countries. We're working on the implementation science, these projects I spoke about. We're working on civil society engagement, like engaging with all of you to help push this agenda. And donors, we need funding, we need donor money, we need government money, we need funding. We're going to build on the lessons we learned from oral PrEP. We're going to work with VIV to overcome some of the challenges and to ensure not just cabotegravir, but there's long-acting PrEP coming down after cabotegravir. There's one lenacapavir, it's 2 shots a year. And so we want to just accelerate this process of moving from research with really good, effective products and results to now to implementing and getting these products to the people who need them most. And I'll stop there. I just want to draw your attention. There's a lot of resources. And just going back to here, I meant to say, there's no European representation. We have a key populations working group. We have an AfroCab. We have an African working group. And I want to put out there to you all, if you are interested in joining this coalition to accelerate access to long-acting PrEP, please contact me, and we can consider what it would look like to have a European working group in the coalition if there's interest. So I'll stop there. Thank you very much. Oops. I hope that was slow and deep.
Yes, thank you very much. We went a bit over time, but we're taking some time from the presentation. So now we would like to introduce Sarah Demart and Grâce Ntunzwenimana, who will be talking about PrEP and access for migrant women in Belgium, but I guess in general. And so here you go. I understand, Sarah, you will share your slides, right?
That I'm not used to Zoom, sorry. I don't see how I can share my can you share it for me? And I will
should be a green arrow.
Authorization to move the slides.
Yes. We will share it.
Yeah, thank you.
I have it also. You share. You can share. Okay. Can you?
Yeah, sure. So thank you very much for the invitation. This presentation is based on a research action that I've been conducting with Émilie Gérard. So I am a sociologist. I work at the Observatoire du Sida et des Sexualités in Brussels. And Émilie Gérard is a prevention manager. She works at the Plateforme Prévention Sida, which is a prevention organization based in Brussels. And I'm going to share some results of this research called FemiPrEP. You can move on. Yeah, next slide, please.
Oh, sorry.
No worries. So where we have been trying to better understand what could facilitate and what are the structural reasons why women of African descent, African migrant women, do not take or use PrEP. So I'm not going to follow each step of my PowerPoint because it's a 20-minute PowerPoint, but I'll be happy to share with you the PowerPoint if you want to get more details. Next slide, please. So the starting point of this research action, and it's really in line with what has been presented by Cindra Feuer, is we're going to really focus on a specific group, and in particular a key population that has been a priority for the prevention organization or in the epidemic since several decades now, but this key population is completely absent from a delivery system of PrEP. So this is what we have been trying to understand. And in the Belgian context, where PrEP is an ambivalent offer because it is presented as a global response to the epidemic, like everywhere in the world, but at the same time, undocumented people do not really have access to PrEP. There's something quite ambivalent because as undocumented people, they do not have any insurance policy, and the urgent medical assistance, it's not very clear whether they can have a reimbursement of PrEP. So for now, PrEP has been made available in Belgium since 2017, but most of the promotion and the feasibility studies have been directed towards MSM. Yeah, next slide, please. So in the FemiPrEP research project, we have different lines of research, but what I'm going to present is really, it's a one-year research we've been doing during the pandemic, where we have been questioning the prevention professionals to understand or to know, according to them, what are the reasons why African migrant women, a key population, is absent from PrEP delivery system. So we have been really focusing on their point of view. Next slide, please. Doesn't work?
I'm sorry, no, it's not working. Oh,
so while you try to move,
right.
So the research have been conducted between May 2021 and June 2022, approximately. The health promotion in Belgium is organized by sector. So you have the sexual health promotion organizations, you have the more health promotion organization, some focused on women, some focused on migrants. And here I'm going to look at the results of the interviews we've been conducting with the sexual health promotion workers. So I would call them the prevention experts. And so there's 4 main results that I'm going to present now. 4 arguments of the prevention professionals about the reasons why they believe women of African descent, migrant women, do not take PrEP. So the arguments, some of the arguments focused on the women themselves, and some arguments look at more how the field of prevention is organized. So it's really different type of arguments. So the first one, which is not really, well, yeah, it is. So with the first one, we have 5 arguments, is the fact that the public, so the key population, do not know PrEP. And I think it's a very important result to have in mind, is that the key population is made absent because this population do not know the existence of PrEP. So this is really a shared vision with that. That was like the very first answers we've been collecting. Now, the reasons why the key population is made ignorant of PrEP. A first argument, I would say, relates to the idea that the key population would not be able to deal with the daily management of the treatment. That the key population could not understand how PrEP works because of a lack of prior knowledge and sexual education, because of a cultural taboo of sexuality, because it would be too dangerous with STI. So it would be too complicated for the public, for the key population to understand, and for the prevention workers to explain, also because of lack of time. So the result is that they do not talk about PrEP. This is what you can understand from these arguments. Next slide, please. The second level of arguments refer to the legal limitation of PrEP. It is also related to the fact that prevention professionals do not talk about PrEP, but for different reasons. They do not talk about PrEP because eventually the tool might not be available. Most of migrant women who are at risks, with I quote, are undocumented and therefore uninsured people. And it is not very clear whether the urgent medical assistant can make PrEP available for this population, because it's kind of complicated, and I won't develop this now because we have no time. But people say, okay, prevention professionals say, okay, PrEP is quite expensive. Migrant undocumented people may have other material priorities. The follow-up to this public for prevention workers might be complicated because it is a mobile population because of accommodation conditions. So it is too complicated and we are not sure they could access. So we do not want to create an offer that cannot be met on the field. So this is the second argument why some of them do not talk about PrEP. Next slide, please.
I'm sorry,
It's okay, again.
I have a
So the third argument relates to the biomedicalization of PrEP. The fact that in Belgium, PrEP for migrant women, because it starts to be different. It is different now for MSM and for trans women, but for heterosexual, cisgender women and African migrant women, having to be getting PrEP needs to go to hospital. So it is a kind of complicated pathway because PrEP is delivered within HIV service within hospital. So there is this proximity between having HIV, asking for prevention, HIV treatment. And so in terms of stigma and in terms also of making the whole the different steps to get PrEP is a bit complicated because you need to find the information. Once you get the information, to make an appointment, sometimes you need to wait. You have a very closed follow-up. And also you have no, it's next slide, please. And also you have the kind of questionnaire. Sometimes you have questions about why do you think you need PrEP? So the discussion on sexuality, and some of prevention workers say so this discussion on sexuality and risks has been made from MSM experiences. MSM from the north, maybe white MSM from the north. And it's not a discussion that has been thought in relation with migrant communities. And so it can be uncomfortable. And also some have been mentioning refusal of giving PrEP, but this is something we have not been able to double check. So here the argument is that there is a discouraging device really in terms of PrEP. And so the final argument is a more political one, and it looks at the other three different arguments and say women don't get the information, it is a problem. They have the right to information about PrEP, whether it is available or not for them. And if it is not available for them, they have the right to have an advocacy, a lobby as a specific population. For example, there could be an advocacy for having PrEP for everyone, undocumented and uninsured people included, which is a fact in France now. PrEP is available for everyone. And so here the argument is the prevention workers sector needs to change the representation of the population. There is too much focus on sexuality as a taboo, on a population that would be able to manage, to understand, etc. Sometimes some people believe it is racist, and so the discussion on PrEP should be articulated to a discussion on what are the valuable population, how race and prevention articulates, etc. And so I'm going to leave it there because this is a research action that I've been conducting with the Plateforme Prévention Sida, and Grâce Ntunzwenimana is with us. And so she's going to present now what is the follow-up of this research action. So I'm not going to give more elements of analysis, but really to leave the floor to Grace to explain what, with this research action, what is the follow-up in terms of prevention. But I don't have your PowerPoint, Grace. I can't, and so I think it's Chiara will.
I think there's no problem. Maybe, thank you for the invitation. So Sarah spoke about the barriers, so I'm now not going to talk it again because she speaks about the lack of information, also the system model of delivery PrEP in Belgium, and also the cultural and the religious taboos. So I am going to talk about actions we implemented, because I think that we know that women are in need of PrEP, and we have to do something to let them have it. So what we do here in the Plateforme Prévention Sida, we try to empower and enable women to make decisions about their health through community campaign to increase their knowledge on PrEP. So we do it, we do posters, flyers, and videos in the maternal language. We try to do the information in the language they could understand. And also we do the animations with tools adapted. So sometimes we try to use just the pictures because some of them don't, maybe they don't have education. It is very complicated for them to understand some, if there is no image. So we try also to train the community relay who could go and sensibilize other women. And also we develop a community guide on PrEP. We try also to train the professional, as Sarah said, some professionals don't know about PrEP, they don't talk about it. So we try to sensibilize them and also to let them be able to talk on it. And also we involve women in all our project process from the beginning to the end. So we do with them and not do with them and not doing for them. So we try to propose them a positive sexual health perspectives to strengthen women's ability to make decisions for their sexual health, and by allowing them to be a voice speakers on sexual health in their community. We try to let them to be the voice speakers in their community. So last year, for example, we launched a woman project. So we train at the beginning, we train women, and that women after went in their community to sensibilize their community. It was only on PrEP, it was on the sexuality health. And that project, the aim of the project is to allow the women to have a well-being and sexual health. So we touch more than 100 last year. And that project now will be enlarged to the men, because on demand of the women, because for them to talk only to the women without men, maybe it will not work. So this year we integrated also the men in that project, but the women still be the leader of that project. We also give women information they needed and try to find a solution for their situations. Sometimes if there is emergency or an agent for PrEP, we try to collaborate with some organizations which are able to give to PrEP. There is one organization here in Brussels, so we collaborate with them, and if we have someone who needed PrEP in emergency, we try to send the person to them. We do also advocacy with authorities to facilitate access to prevention tools as PrEP to vulnerable migrants. And also, as Sarah says, the river model in Belgium is only in the HIV reference center. And we know to go in that reference center, you need to have an appointment. Sometimes the appointment, you have to wait for a long time. And also in that services, also it is a services normally for people living with HIV, and some people don't want, women migrants or migrants don't want to go there because for them, if they go there, people could think that they are also HIV positive. So they don't want, sometimes they don't want to go there. So we try now to do advocacy that GPs could also prescribe PrEP and also make PrEP available in community organization, which is very easy to go for people, for migrant people. And also it is, they know, sometimes they know the relationship they have with people working in the organization is not the same that people working in HIV reference centers. So we do advocacy for that. And also we try to sensibilize politicians because they don't wait people to be infected to give them medication, because it is also, it costs so much, but we ask them to give them, to try to prevent before to wait people to be infected. So there is a pilot project which has been presented to the authorities. We hope that project will be acceptable. We don't know it's very well, but we hope that the authorities could accept it, because it's a project which will give PrEP to the vulnerable people, the migrants, and also the women. And we continue to do what we can by sensibilize the community and also the politicians. Thank you.
Aisuluu, are you there? Okay, so we'll thank you. Sorry again, Sarah, for the slides. And so now and thank you very much for your presentation. So we will move on to the intervention, and thank you, Grâce, to the intervention of Erica from GATE and Amanita Calderon from TGEU. And then we will go to the questions and the comments and the discussion. Thank you.
Well, hello, everybody. How much time do I have, Anis? Like, considering the circumstances?
Yeah, considering the circumstances, you had 20 minutes for the two of you, so 10 minutes. But, you know,
great, because Erica's not here.
Because there are quite a couple of questions in the and discussion points in the chat, so it would be great if we had time to go.
Yes, I understand that. I don't think Erica's here. I mean, unless, is Erica here somewhere in there? Nope. Okay, but then that's great, because I think I'm just going to basically present for both of us. And yes, so I'm gonna share my presentation here. Please allow me a second while I go up here. Great. So good afternoon, everybody. My name is Amanita Calderon. I am the HIV Research and Advocacy Officer for TGEU, work hand in hand with Erica Castellanos, Executive Director of GATE. We both go by she, her pronouns. I also use they, them pronouns. We both, Erica and I, and TGEU and GATE, together with UC Trans and with Ethan, the East African Trans Health Network, we have created this consortium called the Thrive Consortium, which is currently working on both local, regional, and global level on different forms of HIV research and advocacy. And one of them is what are the challenges that the trans communities face when it comes to access PrEP, antiretroviral treatment, PEP, different forms of treatment against HIV/AIDS. So today, what I will be presenting to you is a little bit of a literature review that presents a more with more clarity what are these challenges, but I'm also going to be talking to you from the preliminary data that we have been collecting throughout some community-based qualitative research that we are currently leading at the Thrive Consortium. So to begin with, I would really like to highlight that whenever I will be talking about further marginalized members of the trans communities, I will be specifically talking about these 5 communities, not because these are the only further marginalized communities, but because these are the ones that are highly or the most affected by HIV/AIDS and by other sexually transmitted infections. So I will be talking about specifically trans asylum seekers and undocumented migrants, Black, Indigenous, and other trans people of color, trans sex workers, specifically trans feminine people, trans people that use drugs, because I will get back to this eventually, but it's not just people that inject drugs that are in a high risk. Erica Castellanos, just to answer your question, Cindra, Executive Director of GATE. And trans people that inject and use drugs, because both can increase the risk of contracting HIV. Sure. And finally, trans people in prison. We're going to get to a point where we'll be talking about how systemic oppression and systemic transphobia and cisnormativity increase really high the risk of trans people to be criminalized and therefore eventually to be exposed to many other forms of practices that increase the risk of contracting HIV. But to come back to the topic, which is access to PrEP, I want to present to you a figure, the first figure that was presented last year in July by the ECDC, the European Center for Disease Control evidence brief titled Pre-Exposure Prophylaxis for HIV Prevention in Europe and Central Asia. In this figure, what you can see is the amount of countries in Europe and Central Asia that actually allow or that have implemented PrEP within their countries, whether it is available for the citizens, whether it is available and reimbursed, whether it's not, it is available but not fully reimbursed, or if it's just simply not implemented within the guidelines. What we can see in here is that about 20 countries stated that PrEP guidelines had been developed and are being implemented, 22 out of 55. So that gives you an idea of, at least within the legal framework and without counting the fact that some people are not documented, this is how accessible it is for citizens, for trans European citizens, okay? Now, if we continue in here, we follow to the next figure that they presented on the evidence brief, and we find that only 22 countries out of the 30 countries that answered this question granted PrEP or made trans people eligible for accessing to PrEP entirely based on their gender, on their gender identity. We can also see the same, the numbers for gay, bisexual, and other men that have sex with men, which was 28. Well, for sex workers, it was only 18. And for people that inject drugs was only 13. For prisoners, however, it was only 6. If we continue in this table, it's a little bit more precise about the situation in Eastern Europe and Central Asia and Eastern Europe, where we have total numbers answering the survey. 22 countries in total answer this. And what we see in here, specifically, I wanted to highlight that only 12 of them, just a little bit more than half of these countries, actually have included, actually have HIV guidelines. And only one of them, one of those 22 countries, has a specific PrEP guidelines to determine which members of the key populations and for the further marginalized members of the trans communities can have access to PrEP. Only one. That is a really small number. And just giving you also an idea about the economical situation, only 5 countries have free of charge access to PrEP within the public health system. So that is, again, a really small number. And if you actually take a look at the evidence brief that I mentioned just before, you will be able to see how incredibly expensive this can be. So these are the general legal framework that is happening in Europe and Central Asia at the moment for Western Europe and in Eastern Europe and Central Asia. I am going to move on a little bit to talk a little bit more with more detail about how is the case for the further marginalized members of the communities. And the reason why I want to do this is because I need everyone in here to understand that it's not like whenever we talk about trans people, yes, trans people are key populations. Yes, we're in high risk of contracting HIV. But when it comes to preventing infection and when it comes to treat the infection, and control the infection, it is very specific intersections between race, gender identity, gender, migration status, and economical, like socioeconomical status, the ones that are going to allow a higher access or less access. So we cannot just simply talk about rates of HIV among trans people. We need to talk about Black trans people. We need to talk about undocumented migrant trans people. We need to talk about trans sex workers and trans people that use drugs or that are in prison. It's important to do that. So in the figure 7 from the evidence brief that I talked to you before, it shows the availability of PrEP for undocumented migrants, which is like what you can see is that out of the 55 countries that reply, very, very few, and most of them Western and Northern Europe, are the ones that have available PrEP and available PrEP with a price. So again, a really small amount of countries in here. This figure, I'm not going to get so much into this figure, especially because there was just now a presentation talking about migrants and the challenges that they face. But I really want you to pay attention to this figure in here, because this can be reproduced in many other aspects, not just for migrants. There's always going to be a regulatory level, a health system level, a community level, an individual level group of factors that will make it more difficult or easier for people to have access to this type of medication, or in this case to oral PrEP, but in general to antiretroviral treatment, to PEP. Eventually we will be seeing the same issues with long-lasting PrEP, and if that ever happens, vaccination. So the reason why I wanted to highlight this is because trans people in general, for example, like imagine we change the word migrants in here for trans people. We also experience, for example, a lot of transphobia within the health. Oh, sorry. No, why is this being so rebel? There you go. We experience a lot of transphobia and systemativity within the healthcare system, which that comes from medical doctors and nurses, mostly medical doctors, which reduces their empathy and their capacity to provide a gender-tailored service that makes trans people feel comfortable within HIV-related services. That is one of the main reasons why what we found out that there is so little adherence to PrEP and ART from the trans communities. Just to go back to what Cindra was mentioning in her absolutely wonderful presentation at the beginning of this webinar. So if you pay attention to the different components in here, what you will see is that there is a lot of layers that can actually lead to increase or decrease access to oral PrEP from the trans communities. Now, there is a really high number of countries in the world that retain punitive laws that are used to target trans people. And these laws go from punishing people for cross-dressing or impersonating the opposite sex, as well as laws that are related to same-sex sexual activity. And that basically means that when we're talking about trans people in prison, we're not necessarily always talking about thieves or about people that have, break the law as we understand. We're literally talking about people that are being punished and incarcerated because of their gender identity and also because of their sexuality, and how these two things play along. So and these can be seen in the case of, am I getting a message? Okay, I actually just got a message from Erica, but we'll get back to that later. So there is a really high risk for trans people everywhere, including Europe, to being incarcerated or to be criminalized. And then just to mention that the HIV prevention and treatment and care programs are often lacking in prisons in closed systems. So, I mean, we do need a lot more research on this specific topic, but thanks to the United Nations Office on Crime and Drugs and Crime, UNODC, We know that there is a really high number of trans people or of prevalence of HIV among trans people within the prison system compared to cisgender people. We also know, for example, thanks to UNODOC, that transgender people in prison are also estimated to be up to 13 times more likely to be sexually assaulted than cisgender people in prison. So all of these things, all of these components, the fact that there's no gender affirming care, the fact that there is no legal gender recognition within the prisons, and the fact that we are in high risk of ended up consuming drugs because of mental health issues, the fact that we can easily be incarcerated because of our gender identity, because of our sexuality, or because we're doing sex work, which is also criminalized in several parts of the world, including Europe, because of all of these reasons, and the fact that we also are 13 times more victim of sexual assault, then what you have when you ended up is with a really high risk of contracting the infection and then just simply not having access to oral PrEP or any form of prevention in here. And this leads me to what in my opinion is the main reason why it becomes so difficult for people to have access to PrEP, to have access to any form of HIV related service, which is cisnormativity and transphobia. We can see that from a systemic perspective, as I just mentioned before in the other slides, but when we're talking in a sociocultural level, we are, like, I would like to highlight some of the things in here. So first of all, the communities, the trans communities have a really high, there's lack of knowledge about HIV basics and about epidemiology. I have been working with HIV activists from different parts of Eastern Europe and Central Asia that are not even familiar with what PrEP is, how PrEP works, how can HIV be transmitted. So this complete lack of knowledge, which is, well, in my opinion, is completely responsibility of their state, their governments, not informing them, not providing this type of information, not making this information available, but also from the private sector that does not have enough presence within and does not take responsibility for something that they should be taking responsibility on. So then there is a really lack of knowledge about HIV basics and epidemiology. Now, there's also like a really low perception of HIV risk. And that is something that we're quite surprised. A lot of people actually don't know how dangerous this is for them, specifically for them. Again, this is a matter of ignorance and not having very important knowledge that needs to be shared with them. So what do we need to do in this case? Most likely the community, like this peer-to-peer work is the one that is going to fill up that gap, right? Inform people so they're aware of how, for example, PrEP can help them avoid getting this infection. Now, I just put this table in here that is called barriers to PrEP use. And it mentions some of the percentages that are such as lack of knowledge, not being reimbursed, like economical issues, and also in here, as I mentioned before, transphobia and cisnormativity. In the evidence brief that the ECDC presented, like out of 31 countries, it was mostly medical doctors, the ones that had the power to prescribe PrEP. If a medical doctor does not consider you, for example, a key population because you're a non-binary person and you do not identify with being specifically a trans woman, which actually has happened. I'm telling you this has happened because it happened to me in Denmark, that a medical doctor would deny me access to antiretroviral treatment because I would not be considered a key population. So this is the type of things that we have to deal with, right? That trans people in general has to deal with. The fact that many times we are misgender and we are deadly whenever we come to the doctors, because the medical doctors are not educated on gender tailor services, like on how to treat and how to provide for the services of the trans communities. So when this happens, people just don't come back. If you feel like the HIV related services are not a safe space for you as a trans person or as a migrant or as a person of color or as all of the above, you just don't come back. You don't adhere to the treatment, and then you're in high risk of contracting HIV again. Finally, I would like to leave you this little beautiful figure, also left in the evidence brief, of how incredibly expensive it can get to purchase PrEP. across Europe and Central Asia. So in case you were wondering, if you're a trans person who were kicked out of your home at a quite early age, who never had access to education, who because of that became a sex worker, and who occasionally is homeless or lives in homelessness, do you really think that you could afford 434 euros per month of medication? That, like, it's just absolutely simply ridiculous. I'm gonna leave you there, and I hope that I did not pass time. Yes.
No, you absolutely didn't, Amanita. And thank you for a brilliant presentation. I think it's now time for discussion and for questions. And I see that there were several questions in the chat boxes. I guess most of them are directed to Cindra. Maybe Cindra, you want to reflect on some of this before we start?
Sure. And hi, Aisuluu. It's really nice to see you.
Here.
I think the resistance question is a really good one, and it needs some breaking down. It's a little complicated, but it's a common problem in messaging. So, right, people on PrEP who are protected against HIV, what they won't seroconvert. They won't get HIV most of the time. But with cabotegravir, it's a little bit different than oral PrEP. So in the studies, they saw that several people who started on PrEP, everyone gets an HIV test before they go on PrEP, and everyone tests negative before they go on PrEP. You have to be negative. But what happened with cabotegravir, because cabotegravir is so strong, that several people they started they tested HIV negative, but they were seroconverting when they got on the cabotegravir. But cabotegravir reduced their viral load, so they couldn't detect. It took them a long time to detect that they were infected before they started cabotegravir. So once it took a few months for them to detect the infection on cabotegravir, and some of those infections were resistant infection because they developed resistance to the cabotegravir. So those were baseline infections. They were already infected, and then they started taking the cabotegravir. And then there were a few breakthrough infections that might have also been resistant to cabotegravir, because while they were on cabotegravir, they became infected. Perhaps their levels, perhaps they weren't taking enough, or for some reason they took enough, but there were a few breakthrough infections, but they weren't detected for several months. So they stayed on cabotegravir while they had infection. And when you're on monotherapy, when you're on one drug and you have HIV, it leads to resistance. So this led to some resistance. But these were very few cases, but some people are very concerned about there being a lot of cases of resistance. But the thing that's really important is the testing. The tests, so they're saying that tests need to be really sensitive, like more sensitive than the regular fourth generation, so PCR. So they're really, I mean, the ideal would be a viral test, like a NAT test, but that's very expensive, and we don't want countries to only roll out cabotegravir if they can only have those optimal tests. They want it to be, so testing algorithms and what tests are used are up to each country, but some of them have to figure out what's the best testing routine to catch any breakthrough infections and resistance. I know that's really confusing. I'll stop there, but maybe that was too much information.
No, I think it actually helped us to clarify. I hope the person who asks this question has a better understanding of it now. I see there were also several questions to Hirwa related to what was no, it was from Hirwa actually. Oh, I see there was one for everyone, but also to, I guess, colleagues who were presenting about access to PrEP for women, especially when they're migrants. So the question was actually from Cindra, from you. Were the women asked directly what were their barriers for PrEP? So can we ask Sarah and
Yeah, that was for Sarah. That was for
yeah,
me.
if you can answer this question as well.
Yes, we have the video we could find on our website, the
Okay.
Plateforme Prévention Sida website. There is a video on PrEP. And we are going also to do it with the women, because the project began, the women project began last year, but it continues. So we are going to, there is a video which has been to sensibilize PrEP, because the project was with my colleague Emily's wife. Maybe I am not going to give the clearly information, but if you went to our website, normally we find the videos on PrEP.
And it would have this information
also,
as well.
Yeah, and we're also going to do other tools with them, with the women.
Okay, can we ask you then to share the link to your website on chat so that people can have a look? Yeah, thank you so much. And there were also a few more previous questions that I want to read out, and those are from Isator and Elian, and these are for everyone. So maybe some of the speakers can reflect on those questions as well. So first question was from Isator. Does female genital mutilation affect the uptake of PrEP? And if so, do you think it is key to integrate PrEP awareness programs in cultural practices, such as community-based approaches? And Elian also was asking why EMA does not approve dapivirine in Europe yet. Is there anyone among the speakers who would like to answer this question?
Yeah, I just wanted to complete Grâce's response in light with the comment of Cindra. So where the women asked directly what their barriers to PrEP are, because I think it's a very important question. And we have been doing some focus groups for women, and we found some ethical problems to ask women sometimes who are living in the streets to come to focus groups and to be part of the focus groups and just to get some information, and then we had nothing to offer. So this is one of the very structural limitations, I think, for the research. Women were also asking that men should be included in the focus groups, because most of the time for them, they were part of the problem, and it was not possible to just ask women to take the responsibility of prevention practices. And also very quickly in the different focus groups we did with the women, we found some very structural problems in the lack of space for women in terms of sexual health, and the lack of discussion on sexual health and race. And so that's why we've decided to look at more precisely who are the providers of, what are the different obstacles in the systems, more than asking again and again to women to be part of devices where they're not included. And I'm not sure Grâce really mentioned it, but women who were interested in being community relays, now they are part of the research. So in order to have not only a research with white people from research centers or prevention organization, but to think of a collective structure. But it needs time. This also raises issues in terms of money, because you can ask people to to be part of these kind of structures if they are not paid. So this is a whole different kind of project we are trying to build right now.
Thank you. Thank you for this important contribution. And related to the previous two questions about EMA approval of the Dapivirine ring, maybe Cindra, you can reflect on that question as well.
Sure. It's a really good question. So the EMA approved or gave a positive opinion to the Dapivirine vaginal ring for use in Africa. It was a special Article 52, and it was always only meant to be for African countries, because Africa didn't have its own regulatory body, a unified regulatory body. For it to be approved by the EMA in Europe, it would have to be, they'd have to do a completely new and different application for Europe. And so the owner and manufacturer of the Dapivirine vaginal ring was the it's a nonprofit organization called the International Partnerships for Microbicides. They decided not to go to the EMA because there was not necessarily, first of all, it would be really expensive, and there was not necessarily clear that it would be approved because of the rate of efficacy was not as high, and was not as high as, say, oral PrEP, and they did not know if the Europeans would think that the risk benefit ratio would be enough, so it was showing to be perhaps reducing the risk by 50%. They didn't know if that was high enough to introduce it into the populations at risk in Europe, because it was so much more there, because there's so much more HIV higher risk in African countries. They thought an intervention that reduces risk by 50% would still have a lot of benefit in Africa, where rates of HIV are so high, but they're lower in Europe. So the IPM decided not to bring it to the EMA, and they said it would cost them a lot of money. They said they were too small, they couldn't do it. They've actually gone out, they're done, they've gone out of business, and now the Population Council is the owner of the Dapivirine vaginal ring, and they would need to be pushed to bring it to the EMA and apply for regulatory approval.
And I saw your previous message related to whether there is an interest in the Dapivirine ring in Eastern Europe and Central Asia. If there is a demand, I can tell you from my own experience that in Kyrgyzstan, I think the problem in Eastern Europe and Central Asia is that most of the information about scientific innovations are usually in English, and not everyone has fluent English speaking abilities. So quite often they just don't have enough information. And when you talk about the possibility of having long-acting PrEP options, people get really excited and they are really interested. The problem is that very often key populations are not informed about these possibilities like the Dapivirine vaginal ring or cabotegravir. So I think that's something where we should all try to work together. And that was just a remark, but I also wanted to tell to everyone here, if you have comments or questions, please do feel free to raise a hand or something so I can see and give you a floor.
I think we missed one of the questions about whether we should include information on a peer-to-peer work. I think Cindra, you were going to mention something about that. I was also going to respond to that.
Oh, sorry, I missed that. Why don't you respond to that? And then we also need to respond to the the genital cutting and PrEP?
So yes, I am very much convinced that the different key populations need to organize and work together, and we need to keep each other as informed as possible. I think that this is one, like at least at TGEU, that is the whole purpose of having created the HIV Research and Advocacy Officer position, which has 3 angles, one of research, one of advocacy, and one of capacity building. And the capacity building component aims to transfer or to inform the different memberships of TGEU, different local trans-led organizations all over Europe and Central Asia, to keep them informed about, for example, the briefs or the webinars that I attend, and that actually I was in, I think it was you, Cindra, where you know, with it for the ECDC quite recently, where you talked about the latest forms of like the different, like the new technology that is coming up. It was extremely informative. It was absolutely wonderful together with Timur Nuri, and all of this information I am passing on to the trans communities. The problem with that is that in some countries it's illegal to do this. In some countries it's illegal, like especially in Central Asia. Right now, Central Asia is like several different countries in Central Asia are going through a big problem, because HIV advocacy was the way that, like, kind of like the gateway to LGBT rights in there. But then now they're going after HIV advocacy because they kind of like noticed that there was something going on in there. And then now it's like they're cutting down on HIV related services, and they're cutting down on any form of HIV advocacy. And so like the programs where like we could actually come and do this, people are really scared. And it's not just in Central Asia. This also happens in Eastern Europe. It's happening even in the United States of America, where nowadays it's illegal to be drag in some states. So yes, this is needed. In my opinion, this is how we should do it. We need to inform each other. We need to have the higher level research centers and advocacy and legal bodies communicating to the nonprofit organizations, and then we should bring this to the rest of the people. That's definitely a wonderful strategy. Just wish it was not criminalized.
Yeah. Just to the PrEP genital mutilation question and PrEP. I think the question was, is there still, I don't know if it was a scientific, like biological question, but if it is a biological question, yes, PrEP absolutely works, regardless of the status of genital cutting.
Mhm. And I see there was a question from Hirwa as well. Do you want to voice it out yourself, Hirwa, related to PrEP in trans men?
I wanted to know if there was a plan to include trans men in the future.
Sorry, if there was
to include trans men in the future, like in the studies.
Yeah.
Because you know, we have front halls, so we are in need of
yeah.
ring
So
as well.
so in the Depivian vaginal ring, no trans man were knowingly in the trials. In the cabotegravir trials, there were trans men. Not on the scale of anything that was statistically significant. However, I don't know if you saw the slide I put up on the implementation projects. So it's not clinical trial research, but it's implementation research going forward with the cabotegravir injectables. There are 5 different studies across the globe that are including trans men within these implementation trials for CAB. Not their own not their own trans men only study, but within these other studies.
I'm actually a little bit curious, Cindra, now that I have you here, because there is this constant debate about, you know, taking oral PrEP in demand and taking it on a daily basis, depending whether you're a cis woman or whether you are a man that has sex with men. And the thing is, like, I'm not entirely sure if I fully understand what is the correlation in here, because as far as I understood, anal sex was the most risky form of sexual interaction, that because the anus would be like, yeah, would have a lot less barriers to protect the body from the infection, right? So if that is the case, wouldn't that mean that pretty much anyone doing anal sex should definitely be on PrEP constantly, regardless their gender identity or their gender or anything? And that means that also men that have sex with men, trans men, cis men, or pretty much anyone who does anal sex should not be on PrEP constantly and not on demand.
So so the reason why they only prescribe on demand for people without vaginas is because the amount of drug,
The
bioavailability concentrates quicker and more anally than it does vaginally. So you can have less drug and still be protected. Less drug, you can take four hits a week and still be almost 100% protected anally. However, vaginally, it's not as, the concentration is not as rapid and broad. So it takes more drugs for protection vaginally. That's why they're not recommending it. But we're finding now, though, that science is showing, studies showing, guidelines haven't been changed yet, but we're showing now that there is concentration vaginally. Like there's a high concentration. Even they used to say that missing doses, like cisgender women need to take 7 doses, or women having vaginal sex need to take 7 doses a week and not miss anything. Now they're saying, actually, science is showing it's a little bit more forgiving. It's okay to miss a few doses a week, as you know, for cisgender women with vaginas, because the concentration is there. They still haven't done the on-demand studies in cisgender women with vaginas, but that's the reason.
And I mean, it's just like, please make sure that you also have a comparative study with transgender men, because hormones, and especially trans men that are in hormones, have a very different form of genitalia than cis women. So it's very important to have like that clear difference. Like, is this the same or is not?
Absolutely. They've started to do these tests and these studies, and they're showing that that it's looking pretty good as far as on demand. And I mean, I think you're right. I think that trans men on hormones and trans women should be in every single clinical trial, and they should be looking at the drug-drug interactions and what the levels do to their hormones and to the PrEP intervention. It should be required.
I see a hand from Anis, and there are 2 more questions in the chat. So maybe Anis, you go first, and then we can ask Cindra to respond to all 3 questions, if that's possible.
Yes, I'll be short. It was just to thank you all, because we're running over time, but I think the discussion is quite interesting and useful. So if people can leave when they want, but I don't know if Hirwa, Carter, if that's still okay for you. The second one was that I had a question at a time where, you know, financially there's a war, it's challenging, but it's quite evident that we need to scale up prevention and access to PrEP urgently, and specifically within key populations. So how do we make the case for it? And I think you're right, Amanita, that we need to really join forces between different groups, also work beyond the HIV sector to get more different voices to speak for access to PrEP and on the social, I guess, determinants yeah, and there was a question about whether there is a demand for the ring in Europe. I don't know if we got an answer to that one.
Well, I can't answer the demand for PrEP in Europe. I would hand that over to you all. Is there desire?
What was the question? I'm sorry. Can you repeat that? If there's
for the ring, the demand for the ring?
Yes, because we had a discussion in EATG, you know, whether we should scale up our advocacy on that one, but it's unclear whether like what demand there is for it in Europe.
Well, my mind has changed about the ring, because what we're seeing, because I was like, okay, well, if it's not, if you're looking at oral PrEP and cabotegravir, which is like almost 100% reduces risk, and then you have a ring that only reduces risk by 50%. I was like, a couple of years ago, and I was like, oh, why bother? But now I've changed. I was like, you know what? People need choices. Someone might hate needles. Someone might not be able to. We saw the data shows that people can't stay on a drug every single day to be protected. So if there were a ring and a woman was using it and it reduced her risk by 50%, it's better than nothing.
Nothing.
It's better than nothing. And let's allow those women to make their own choice and to not be the gatekeepers of what's available. And I think if there was if people knew about it, and also what they're showing in Africa, where they're rolling it out, when women have a choice, they've actually done studies where they compare new studies recently that are ongoing now, and the preliminary data show that when women can choose between oral PrEP and dapivirine ring, the women who choose the dapivirine ring, they stay on it longer, they're being protected longer, and the women on PrEP are going off of it. So you've got women being protected on dapivirine ring and women not being protected by oral PrEP. So let's not only look at efficacy. Let's not only look at efficacy.
Mm-hmm. And maybe just to echo what you just said, Cindra, I can tell you that I was recently involved in several national dialogues facilitation for Global Fund grant proposal preparation processes in Eastern Europe and Central Asia. And we figure out that actually the problem is that a lot of those key population members are not aware that there is actually such option as cabotegravir or dapivirine vaginal ring. And when you say about it, they say, oh, this is really interesting. Especially this is very interesting for most marginalized women. As Amanita already said, in Central Asia, there is a, there can be a very big influence, quite often negative influence from the male partner of the woman on what she can take and what not. And sometimes due to stigma, she may not be really willing to use oral PrEP, or she may not be in a position when she can ask her in-laws to let her go every 2 months to get her shot from the doctors, as it will be at the hospital setting. But if she is provided vaginal ring, as you said, it's better than nothing. She can change it on her own and she can stay longer on a PrEP and be better protected. So for those who are at high risk of gender-based violence, or for those who are in a more marginalized position, this is really something that we should be providing as an option.
I am agree with you. I think that there is no demand because maybe women don't know that it exists. I think that we have to do advocacy because, as you said, it is the woman could have the choice effectively. So I think that advocacy is needed, and also they don't know. There is a lack of information on it, and also it is not exist in Europe, and so I think that it will be good that in Europe also ring will be available.
Yep. And I see there is a hand. Alian, you're raising your hand.
Thank you very much. So look for my PrEP t-shirt. So when I am explaining to sometimes anything relating to PrEP, I wear this t-shirt to talk to women, especially migrant. And they always say like in Netherlands, it's only PrEP. When they do a PrEP campaign, is more related to sex party, gay peer, like those kind of things. So when I'm trying to talk to the women also can use a PrEP. But then when I heard the news about the ring, the vaginal ring, I was also explaining to them. Then they said like, that's very important. That's good to know that when you wear that one, at least no one is gonna know you have it. You are very protected and you are not afraid that they're gonna ask you, you are taking gays peers, And of course, there is a stigma around that PrEP. And when we need to break the stigma, we have to look how positively we make the message and target also women and trans women, or whatever the community needed. So I think also if if EMI could have approved that the prevailing ring, we could have already get share information, but is no one knows it, and we have to. It's our task to try to bring up the information and do more campaign, you know, so then more women knows about it, and then it's okay. And even if we don't have access to it yet, but at least women have the choices and they have information about it. Thanks.
Thank you.
Sorry, we should probably start to wrap up also, because bearing in mind the time of the translators, interpreters, because we're running over time, and also maybe some people have to go. Sorry for interjecting.
Yeah, so sorry for really, like, I was actually checking with Anis if we should wrap up now, because I was also very sorry to stop this conversation, but I hope it may continue online. And if you have any questions to the speakers, please do feel free to send them to Chiara, and she can forward them to our speakers and help you with disseminating the answers from them, I guess. Thank you all, especially thanks to Sarah, Grace, and Amanita and Cindra for sharing excellent news and information about PrEP. It's highly appreciated, and thank you everyone for being with us till the end. And I guess now the closing remarks are for Hirwa.
Okay, this is the end of our meeting. And if we don't want it, let's do this again, maybe. Thank you everyone for your attention, participation, and interventions, and your presence until now. The recording and report of the webinar will be made available by the end of the month. At the end of this meeting, a feedback survey will pop up on your screens, and I encourage you to give us feedback and tell us how you found this webinar. I loved it. I encourage all of you to keep an eye on the SCOPE project and its developments. Next month, there will be the publication of a SCOPE-funded community research project on transgender and gender diverse people access to PrEP in Greece. Keep in touch to continue receiving updates on community perspectives on combination prevention standards through SCOPE. And before concluding in this meeting, I would like to thank our speakers, Cindra, Grace, Sarah, Amanita, as well as Aisuluu for our moderation. Thank you again to all of you for your participation and questions. Have a beautiful afternoon and happy Pride Month to everyone.
And thank you to EATG for organizing this, and to you for moderating too. Kisses to everyone. Bye, Anis. Bye, Kira. Bye, everybody. Thank you.
Bye. Thank you very much for joining.